inhibition of segmental chronic peristalsis, leading to high amplitude peristaltic contractions. There is contraction of the abdominal wall muscles, and finally the relaxation of external anus sphincter with the expulsion of feces. So it is an orchestrated action which occurs simultaneously in during defecation. So that is how it occurs. There is the acute angle of puborectalis muscle during defecation. It relaxes so that it becomes straightened, and with the relaxation of external anus sphincter, the feces are expelled. So how we classify chronic constipation? It is functional constipation, which we'll be talking in the subsequent slides. Chronic functional constipation, what will I be talking in the subsequent slides. Secondary constipation, we should know what are the causes, secondary causes of constipation, which are amenable, which we can correct and add to the treatment for that causes. So functional constipation is usually divided into three types: normal transit constipation, slow transit constipation, outlet constipation, pelvic floor dysfunction, or defecatory constipation. So this is the third type, which we can call it as an outlet constipation. We can call it as pelvic floor dysfunction, or we can call it as defecatory constipation. What are the causes of secondary constipation? They are many, and they are correctable, and so they should be borne in our mind. What are the secondary causes of constipation? Like endocrine, most common is hypothyroid, diabetes. They are very common causes of constipation. New onset of hypothyroidism can present as a constipation. Metabolic causes, neurological, they're very important. Parkinson disease, they have disabling constipation. Rheumatological causes. Then medications, we should always see whenever the patient comes to us with constipation for OPD consultation, we should always check the medications which are going, which patient is taking for other illnesses. What is how we define functional constipation? Because it doesn't have any biological markers, so we define it by Rome 3 diagnostic criteria. That is, chronic constipation must include 2 or more of the following: these 5 out of 5 features. That is, straining. He has to strain. The stools are hard and hard. There is sensation of incomplete evacuation. There is sensation of anorectal obstruction or blockage, or manual maneuvers to facilitate defecation. Loose stools are rarely present without the use of laxatives, and insufficient criteria for irritable bowel syndrome. These are for only functional constipation. So complete constipation is more than just the infrequent passage of stool. That is, in Asian subpopulation or Indian scenario, it is it's not just the straining or the hard stools, but when we come across during OPD, the patient also complains of not only the hard or straining during constipation, but also incomplete evacuation. Patient feels that he hasn't passed the sufficient he hasn't passed sufficient stools, and he still feels that there's something he want to evacuate. He doesn't he has a bloating, and that is very important feature of constipation, which we often see in Asian subpopulation. What is the prevalence of chronic constipation subtypes in patient? That is, subtypes means normal, transit, slow transit, or defecatory type of constipation. Usually it is normal transit constipation, what we usually see in the prevalence in the population. So less than normal transit, it is the obstructive type defecation, and 25%, but we often see more than 25% in Asian subpopulation. That is 59%. We can say that almost to the tune of 40% we see a defecatory type of constipation, or outlet obstructive constipation. And definitely there is overlap between IBS constipation and functional constipation. Patient with the constipation, you do have an IBS symptoms, and IBS patient do have a constipation. What is the pathophysiology of slow transient constipation, which is not very common? It is colonic dysmotility with reduced high amplitude peristaltic contractions. So there is usually a colonic dysmotility, which we most commonly see in neurological disorders sometimes, and in a diabetic patient, prolonged diabetic patient, we see a reduced HAPC, which is a cause of STC, or slow transit constipation. Now, which is more common in Indian scenario, that is dysenergic defecation or outlet obstructive defecation or constipation. It is the probably 2/3 of cases are contributed by faulty toilet habit during childhood only. There is painful defecation, obstetric or back injury sometimes lead to this type of constipation. And 1/3 of cases, I just that what I told, that there is faulty toilet habit training. What how to proceed with the constipation patient? It's not like that patient has come with the constipation. When we know what are the causes of, or what are the subtypes of constipation, history and physical examination is important. From many perspectives. That is, what is the duration and symptoms of symptom? What are the duration of the symptoms? That is very, very important. The temporal occurrence to other factors like diet or change of lifestyle, medications, bowel and diet diary may help to correlate symptoms with the symptoms. And Bristol stool scale form may also be helpful. I'll be telling you in the subsequent slide that what is Bristol stool form. Physical examination, that is comprehensive abdominal and rectal examination, is important. This is the Bristol stool scale. It has 7 subtypes. One is the hard stool, and 7 is the loose consistency stool, and the remaining are the subtypes or the intermittent forms. This is important if we want to maintain a food and the stool diary. This is important pictorial thing which we can hand over to the patient and tell him that you mark your stools accordingly, and we can see is it a slow transit constipation or it is a normal transit constipation, because we have seen that slow transit constipation corresponds with the Bristol stool scale. That is, type 1 is more common with slow transit constipation. This is an important message. What is the role of diagnostic testing? There is, if we have done history and physical examination thoroughly, there is very few tests which are needed. And more importantly is the CBC, that we should know what is the hemoglobin. Glucose, that I told you, the other secondary, that is the to rule out secondary causes of constipation. Very important is the stool for occult blood. Indication of colonoscopy is very important from a physician perspective, from a surgeon perspective, and importantly from a gastroenterologist perspective. That what are the indication of colonoscopy? The alarm symptoms are very important whenever we have a constipation patient, especially in an old age, with decrease in the appetite, with the blood in the stools, anemia. There is short duration of symptoms. Very important. Recent onset constipation has to be investigated. Whenever when we should obtain the test for colonic function, that is, we know it is, we are dealing with the functional constipation, and it is not as there is not a secondary causes to constipation. When should we go for colonic function testing? Colonic function testing, which will what are the tests for colonic function test? I'll be talking in the subsequent slides. When you suspect defecation disorder or the gastric or the outlet obstructive constipation, or when the patient doesn't respond to the standard therapies. We use for colonic function, we use colonic transit study as anorectal manometry and balloon expression testing and teeth echography. These are, we usually give we can give radiopaque pellets to the patient to the amount the number of the pellets, and the duration is to be given to the patient, that in this duration we give this number of pellets to the patient. We calculate by giving serial x-rays and counting the number of the pellets that they are in the colon. We can calculate the colonic transit time. This is the anorectal manometry. So anorectal manometry assesses the resting and the maximum squeeze pressure of anal sphincters. Presence or absence of relaxation of anal sphincter during balloon distension, that is rectoanal inhibitory reflex, which we test in anorectal manometry. Defecative disorders have inappropriate contraction, which we can see on anorectal manometry. Absence of RAR, that is rectoanal inhibitory reflex, is absent in Hirschsprung disease, which we can diagnose with anorectal manometry. And rectal hyposensitivity suggests a neurological disorder that we can also detect on anorectal manometry. So this is an important test for colonic function. Balloon expulsion test. Patient is asked to expel the balloon and we record the rectal and the anal pressures. So this is the four types of pelvic floor dyssynergia or outlet obstructive constipation. Type 1, type 2, and type 3, 4, which we can delineate from anorectal manometry. Defecography is the another tool to assess the colonic function. We can do it with the barium defecography. We can do it with MRI defecography. This is the MRI picture showing the defecography or the defecation process, very beautifully explained in these pictures. So what are the tests which are important now? This is just the summary of the test which I told you, colonic function testing, to delineate how we can say it is normal transit constipation, it is slow transit constipation, or it is defecative type of disorder. These are all the tests which I explained in the previous slides, and this is how we can summarize. What is the management? Diet and lifestyle modification, very important. Laxatives, time, toilet training, biofeedback techniques, they are very important. There is a lot of evidence, there is a lot of publication to show that biofeedback techniques are important in dyssynergic constipation or defecatory constipation. And surgery is the last resort. Biofeedback therapy is the instrument-based behavioral program based on operant condition techniques. Governing principle is that when any behavior is reinforced, its likelihood of being repeated and perfected increases several fold. So this is important. The governing principle in biofeedback therapy. These are the treatment which are conventional treatment available: bulk forming laxatives, osmotic laxatives, and the stimulant laxatives, and the stool softeners, and enemas and suppositories. We use enemas and suppository when there is fecal infection. What are the new pharmaceutical treatments for constipation? They are lubiprostone, chloride channel activator, linaclotide. It is not available in India. Prochloropride, which is available in India, accelerate colonic transit, and elobic C tablet, which is not available in India. This is the laxative class category in pregnancy and breastfeeding. Lactulose is important from is the category B. It is safe in during pregnancy and in breastfeeding. We also advocate egg polyethylene glycol in pregnancy. Prochlopride is a 5-HT4 receptor. It is agonist, and it causes increased colonic colonic contractions and help in the management of constipation. This dose is usually 2 milligram once daily, and it is usually given orally. Prochloropride. We should be careful in population using prochloropride that is elderly more than 65 years, renal impairment or hepatic impairment. We should use low dose of prochloropride in these subset of patients. Adverse events are the headache and diarrhea. The other treatment which I talked in the previous slides, that biofeedback therapy is very important. Surgery is our last resort. This is the recent position statement by Indian Society of Gastroenterology on constipation, which was published in 2018. It has formed It has various points, which have various statements which it had told, which I told in the previous slides, that stool frequency is higher in Indian subgroup of patients, despite they say that they have incomplete evacuation. Constipation associated stools are defined by Bristol type 1 and 3, which increases the diagnosis sensitivity of slow transit constipation. There's very important statements which position statement of Indian Society of Gastroenterology published in 2018. An initial treatment of chronic constipation should include lifestyle modification and osmotic laxative. This is what is the briefing. What I told you in the previous slides. I'm just briefing, and what is they are telling you the Indian position statement of ISG. Fiber supplement should be avoided if patient is already on high fiber diet. Drugs stimulating colonic motility should be preferred for management of slow transit constipation. Is important. Slow transit constipation patients are usually managed. They usually need a high dose of laxative, and they needs two or more laxatives for the relief of constipation. That is slow transit constipation. The top-down approach should be preferred in slow transit constipation patients. So this is the summary that the chronic constipation, the test and how to approach the evaluation and the management. This is the last slide which I summarized for the evaluation and for the management of the chronic constipation defined by Rome 3 criteria. So chronic constipation is one of the most frequent complaints. Defining refractory constipation is a clinical challenge, and mind you, the treatment is also a challenge. Prudent and judicious use of patient counseling, drug like propylapide and non-pharmacological approaches is required. Surgery does have a role to play in some selected rare cases. Thank you.
Yeah, thank you very much, Dr. Meet, for giving your informative insight about this topic. I hope that this information really helps to our audience for day-to-day practice, sir. There are few question answers, sir, from our audience. Like first one is dose modification required in any comorbid condition? If any, please share, sir, for procalciprate.
Yes, hello.
Yes, sir, you're audible, sir.
Prochlorpride is definitely a novel pharmacological agent for chronic constipation. I usually use prochlorpride in a subtype of patients, in a female patients, and who have young female patients who have chronic constipation, more of a slow transit or normal transit constipation. It should be used with in cautions with elderly people, that is age more than 65 years. That those should be decreased, and definitely in renal impairment and in hepatic impairment, the reduced dose of 1 milligram should be used.
Yeah, Rajesh.
Right, sir.
At that time, na?
Sir, the next question by Dr. Sandeep. Doctor, some of my patients, they are very old, more than 65 years, he mentioned, whom I advised procalciprate 1 mg, but as per their experience, effect was not satisfactory. So should I increase the dose up to 2 mg? Any monitoring you are suggesting, sir?
So, Naveen, Dr. Naveen, and he has joined now, na? Santosh is there. Huh?
Hello.
Navedan, first, Dr. Naveen.
Yes, sir, you're audible, sir.
Yes,
I guess.
If the response of prochlorpride 1 milligram
Dr.
above age
Naveen
of
is yet to
65
join.
years is inadequate,
Yeah.
there is no need to increase the dose of
Santosh
the
has joined, na?
prochlorpride. You can use another laxative or can add
Yeah.
on the other laxative. The laxatives armatorium we have other than prochlorpride, it should be used. We should not increase the dose of the propilopride more than 1 milligram in a elderly patient. So we should add on the other laxative.
Right, sir. Sir, next one by Dr. Deepak. For the initial period, we are starting propilopride along with laxatives. What is the timeline we should continue the laxatives?
Time frame for defining the laxatives in a chronic constipation. I'm talking about chronic functional constipation. So the functional disorders, they usually have a relapsing and remitting courses. So they do need laxatives. We have to use them chronically in these patients and chronic functional constipation because of remitting and relapses courses. Regarding the duration of propilopride, the long duration, more than 3 months, more than 6 months, the data is still not adequate. So if you want to use for chronic, chronically or more than 6 months, more than 1 year, as I told you that we do need them in a functional chronic constipation, then other laxatives can be added on. And I forgot to mention about polyethylene glycol. It has the safety other than pregnancy and lactation. The safety of polyethylene glycol is much more than the routine laxatives available and the novel pharmacological agents that are available. So polyethylene glycol is safer and is probably more efficacious than other laxatives available. So polyethylene glycol should be added along with the propilopride or any other novel pharmacological agent.
Yeah, right, sir. So the next one is about constipation is the most common in patient on chemotherapy. So can we give propilopride? Can be given to the patient on chemotherapy, sir?
Propilopride in
Chemotherapy patient, sir. Chemotherapy.
Chemotherapy patients, I told you that these are the normal pharmacological agents. The data is not much available with us for the safety of these drugs. So the pharmacology, if the patient is on chemotherapy, it is better to use the laxatives which are already tested, which have evidence. Like I told you, polyethylene glycol.
All right, sir. Sir, next is doctor. Many patients come up with the cramps after taking propilopride 1 mg dose. So, what is your suggestion for that type of patient, sir?
Cramps after propilopride, I told you there is side effects of diarrhea and headache with the propilopride. If they are already taking on 2 milligram, then we can reduce the dose to 1 milligram and add to it as a bulk forming agents with the propilopride.
Right, sir. So, sir, the next one is about propilopride is effective in gastroparesis, sir.
Propilopride is not effective in gastroparesis. It is not used in gastroparesis. Uh, the data which has shown that the most effective drug in gastroparesis is metoclopramide, that is Perinom, by the trade name of Perinom.
Yeah, sir. This is the last question. This is by Mr. Sameer. Now, what is the treatment timeline we should look up for the optimal response with propilopride, sir?
We should wait for any laxative. We should wait for 10 to 15 days for the laxative to show its effect with any laxative, without increasing the dose or switching to other laxative or adding on the laxative. We should always wait for 10 to 15 days.
Yeah, thank you very much, sir. It was really an informative webinar. I think our audience definitely will find useful about your information for this particular topic, sir.
Thank you.
Thank you very much, Dr. Meet, for giving a pleasure time for this. Thank you, sir.
Thank you. My pleasure.